Greetings, everyone, and welcome to day 2 of the 11th Annual Symposium on Global Cancer Research. We're grateful that many of you were able to join us for yesterday's Early Career Investigator Day. My name is Mishka Kolisira. I'm from the Center for Global Health at the U.S. National Cancer Institute, and on behalf of the ASGCR Steering Committee, it's my pleasure to welcome you. Before we begin today's proceedings, please be reminded that we have a few virtual symposium logistics to remind you of. So the symposium will be recorded and will be made available after the event on the events site. And we do ask that attendees remain muted throughout the event. If you do experience any technical difficulties, you can send a message in the chat to AV support, Des McNeil, and he can assist you. And please use the chat for questions and comments throughout the event in the next couple of days. And importantly, please note that simultaneous translation is being offered for the first time for ASGCR in French and in Spanish. So please take a look at the Zoom window at the bottom of your screen and select the interpretation globe and select one of the 3 languages, English, French, or Spanish. And please make sure you select one of those 3 languages in order to hear the audio correctly. You're also welcome to join us on Twitter and use the hashtag ASGCR23. Now, without further ado, allow me to pass the mic for opening remarks to someone very well known and highly accomplished in this field of global cancer research and control, and someone I am now fortunate to refer to as my colleague, the Senior Scientific Officer and Senior Advisor for Clinical Research at the NCI Center for Global Health, Dr. Ophira Ginsberg. Dr. Ginsberg, over to you.
Thanks so much, Mishka. It's really such a pleasure to be here. Welcome, everyone. Today's theme, as you know, is closing the research to implementation gap. And this is really an opportunity for us to think together about the key challenges and opportunities that we all face to close this gap, as this continues to be a major priority for global cancer control. Now, I like to think that ASGCR really presents a unique opportunity and a unique venue, especially as we can all come together in a virtual way now, for the global oncology research community to exchange information and ideas and to identify how we can come together to collaborate better. As some of you know, the symposium was organized and still is organized as a satellite meeting of the Consortium of Universities in Global Health, or the CUGH, that's holding its 14th annual conference this year. ASGCR 2023 was developed as a collaboration between the U.S. National Cancer Institute and the partners that you see here, including the AACR, ASCO, ASPO, the American Society of Preventive Oncology, AORTIC, who I hope everyone knows well, and also RINC-SLACOM, Building Leadership in Cancer Control in Latin America. What I'd like to do now is tell you a little bit about the NCI, for those of you who don't know. The NCI was established by the National Cancer Institute Act of 1937, and in its current form by the National Cancer Act of 1971. And what some people may not be aware of was that global was always a part of the National Cancer Institute that leads, conducts, and supports cancer research across the nation to advance scientific knowledge and help all people live longer, healthier lives. That is our mission. And here with the red circle, you can see our director in the Center for Global Health is Dr. Satish Gopal, who leads the Center for Global Health since, my goodness, 3 years already. CGH was established in 2011 to incorporate cancer control into global health programs to foster relevant research activities in the global sphere throughout the NCI extramural and intramural divisions, and works closely with many collaborators having shared objectives, including many of you on this call. You can see our strategic plan online. We encourage you to have a look at it. There should be a link in the chat. The strategic plan was published in 2021. And on the left panel, not to be repetitive, but just to see where CGH's mission fits within the NCI mission. That is, to support the NCI mission by advancing global cancer research and by coordinating NCI engagement in global cancer control. Our vision is reduced worldwide cancer suffering through global scientific discovery and dissemination. We acknowledge our responsibility in supporting the NCI mission through our focus in global cancer research and control, and understanding the priorities and needs in the field, considering that NCI is the largest funder of cancer research in the world. Our values are impact, equity, and collaboration. Impact mirrors the NCI and CUGH missions to improve people's lives by reducing cancer morbidity and mortality. Equity reflects our belief that all people should benefit from cancer research and that studying cancer anywhere should benefit people everywhere. Collaboration indicates our awareness of the enormity of cancer as a global public health problem beyond the capacity of CUGH or NCI or any of us to do alone. Our strategic plan was launched in 2021 as CUGH was commemorating its 10th anniversary to further describe our vision and to provide us with a framework to guide the center's activities for the next 5 years. And once again, I encourage you to have a look at it on the website. Just one more slide to highlight some of our research themes and to see on the left-hand panel our priorities, including research, research training, dissemination, and partnerships. So research themes are further described to mention here in line with our training priority, especially, which is obviously the focus of yesterday's meeting. And thanks to Dr. Sudha Sivaram, who led the Early Career Investigator Day. I hope everyone who attended enjoyed it. I sure did, as we all did. And we can watch it together. You can watch it in your homes as you wish once the link is posted. And if you have questions about that, you can put it in the chat. Dr. Sivaram is also coordinating the NCI Global Training for Research and Equity in Cancer program, now known as GlobeTrek, to support and build research environments to conduct locally relevant cancer research in LMICs. Now, among these themes on the right panel, you can certainly note that accelerating global cancer implementation science is one of our key themes, and that is the subject of this year's meeting. We also have among our themes the goal to accelerate technology development for global cancer control, to understand and address global cancer health disparities, which arguably is cross-cutting throughout our work, to increase support for cancer clinical trials in low-income and middle-income countries, and to increase the understanding of cancer etiology and biology through global collaboration. Today, we have a very full and exciting agenda, including the first scientific session, Learning from Our Peers, Translating Advances in Implementation Science in HIV Care to Cancer Control in LMIC Contexts. Then we'll have a break around 10:15 and transition to Gather. For those of you who don't know what Gather is, please stay tuned, look in the chat. This is our really fun, interactive way to connect with the poster session leads. And you can meet the abstract authors between 10:20 and 11 a.m. Then we have the oral abstract flash talk session, and you can see the two topics here: prevention and early detection, diagnosis and prognosis, and treatment and cancer control, survivorship and outcomes research. And then there'll be some closing remarks. So without further ado, a little introduction to our first session, Learning from Our Peers. The session chairs are Drs. Elvin Gang and Thomas O'Denny, who many of you know. It's my pleasure to introduce both of them as session chairs. Dr. Elvin Gang is professor of medicine at Washington University in St. Louis, where he directs the Center for Dissemination and Implementation. He's a physician who trained in infectious diseases, and his work seeks to apply contemporary concepts in implementation science to advance our public health response to infectious diseases, as well as to advance the scientific conceptualization of implementation. Dr. Gang serves in an advisory capacity for the World Health Organization, for non-governmental organizations, and professional organizations to advance strategies for HIV treatment success. Dr. Thomas O'Denny is an assistant professor of medicine, also at the Washington University School of Medicine in St. Louis, United States. His clinical research interests include reducing disparities in clinical trial eligibility and expanding treatment options for cancer in people living with HIV. He's leading an initiative to establish a formal program in global oncology between Washington University in St. Louis and the Kenya Medical Research Institute to serve as a platform for training of a new generation of globally oriented physicians who will advance scientific discovery for underserved populations with cancer globally. It's my pleasure to introduce them both, and they can take it from here. Thanks so much.
So, again, it's a pleasure to have the opportunity to have this conversation this morning. And, I wanted to start with a few reflections before getting us into the panel discussion. So I want to put us in a little bit of a time machine and take us back to 2004. And I work in infectious diseases, and most of my work has been in and around HIV. As many of you know, 2004 was considered probably the worst year in the HIV pandemic around the world. There were probably close to about 2 million deaths from HIV. And that's not that far off from the number of reported deaths from COVID, actually, in the first year of COVID in 2020, which was probably which has been reported in the 2 to 2.5 million range. Of course, the HIV pandemic was different because some regions of the world were more affected than others. And in some places, life expectancy fell by as much as 20 years or close to 20 years in Southern Africa. In 2004, however, a global response was emerging. PEPFAR, that all of you are familiar with, Global Fund and national investments were reaching a point in which real global action was going to start. But there were also naysayers and skeptics. I'm unfortunately old enough to remember those days when there were certain public health folks felt like treating HIV around the world was not feasible, and there was a lot of debate about how to move forward. But it's been a remarkable 20-year journey. The UNAIDS estimates that the global scale of HIV treatment, which has made treatment available in almost every place around the world, has saved 80 million life years. Mortality from HIV around the world has fallen probably 75% since its peak. And although there have been opportunities to do the work better, there are still, I think, many signs of success. So to be back to the future now with global cancer control, we see a situation where there's rising morbidity and mortality with malignancies globally. At the same time, we do have efficacious screening and treatment methods, and we will have more soon. So how do we get it done? How do we take cancer control globally to the next level? Well, it will take many things, the right financing, the right political will, but I think we're here perhaps in part to contend that implementation science will be a part of that solution. Not obviously sufficient in and of itself, but an important supporting role. And in that process, in taking putting implementation science center stage in global cancer control, there's a real opportunity to perhaps learn from both the successes and the shortfalls of the HIV response. And I know, as I mentioned before, there's policy entrepreneurship, there's advocacy and solidarity, and then there is an opportunity to learn scientific lessons about implementation. I'm just going to throw 3 quick things out there and then introduce our speakers. One, we know that community-based strengths in the HIV response have taken some time for the response to realize, I think, how important that is, particularly in settings where health systems have gaps in the formal healthcare workforce. There are many studies, including randomized trials of working with religious leaders, working with traditional healers, community-based and lay services that improve the performance of health systems that cancer can and should draw from HIV. We also realized in the HIV response that initially it was all about simplification and standardization, and more recently it has evolved towards what's been called differentiated service delivery models. So the idea that different people, different patients need slightly different things. And I think that evolution from a one-size-fits-all to services that are segmented is an important lesson. And finally, I think it's important to think about the behavior change of organizations and systems and not of patients alone, where some of the early research focused in HIV around treatment outcomes. So that said, there are great opportunities, but there are important scientific questions as well. So how much research that has been done in HIV needs to be repeated for cancer? I think that's an open question. What can be adopted, essentially cut and paste? There are probably opportunities to do that as well, but require some, I think, interrogation. So today we have three speakers that I've had the good privilege of knowing some for some time, that will present their work and also give us insights about the answers to these questions. Dr. Dan Wu is assistant professor at the London School of Hygiene and Tropical Medicine and also at the Nanjing Medical University in China. Her work focuses on a novel mechanism of mobilizing resources. Pay it forward. I encourage you to take a look at some of her publications. There's a QR code to one of her papers here. And I think this is a very novel area that will be of great interest to folks. Dr. Thomas O'Denny, as you know, is assistant professor at Washington University, has done a lot of work in mobile health, and has worked within implementing organizations for many years in Kenya during the early phases of PEPFAR, and therefore really truly does have hands-on firsthand experience with this work. There's a QR code. And then Dr. Izakanji Sikazwe is Chief Executive Officer of CIDRS in Lusaka, in Zambia, which is a large NGO that helps the ministry and other organizations implement public health activities. Please see a recent paper by Dr. Sikazwe on the role of NGOs in the HIV service delivery response. Each of the speakers will talk for about 10 minutes. We'll take perhaps one clarifying question if we can, and then we'll end with a 15-minute discussion session where all the speakers will be panelists. Let me just finish by putting forward this quote from Nelson Mandela. Let us, I think, not the task of global cancer control is obviously an enormous task that will take many stars to align for progress to be made. But remember, he said it always seems impossible until it's done. And I think that the HIV response in some ways is a great example of that. And we hope that the future of cancer control will also be as well. Let me stop there and hand it over to the first speaker, Dr. Dan Wu.
Thanks, Alvin. Let me just pull up my slides. Are you all able to see my slides now?
Yes.
Great, thank you. Thanks, Alvin, and everyone for the opportunity for me to present some of our experiences that are taking place in from the global south in China. So my talk is about a pay-forward strategy to improve HPV vaccine uptake among 15 to 18-year-old girls in China. And a little bit background on the topic. So globally, over 15% of the cervical cancer-related deaths occurred in China. However, only 1 to 2% of the prior age group girls are vaccinated, and around 10% of the catch-up age group girls received the HPV vaccination. And there are many reasons for such a low uptake of HPV vaccines in the country, such as limited public funding for HPV vaccine for girls, especially for the catch-up age groups. There's some local governments covering costs for 13 to 14-year-old girls, but it's a very small number of cities which are relatively developed in the country. And there are also lack of appropriate community engaged messages or campaigns promoting HPV vaccination, and all of these factors caused delayed vaccine uptake of available products in the market, which is the bivalent HPV vaccine. So having this problem, our team proposed this solution called Pay Forward. So basically, Pay Forward offers participants subsidized services, i.e. the HPV vaccine, as a gift to our participants. And then we also offer them an opportunity to voluntarily donate or write a postcard message to support more people. So the framing from our program is more like giving this gift as, giving this service as a gift that is already paid by the community members. So leveraging the community generosity and kindness for this HPV vaccination promotion. So very high level components of the model are first is the financial component, because we provide a small subsidies to the participants, and then we also offer opportunity for them to voluntarily to donate to our initial pool so that we can sustain some financial sustainability. And then we leverage this human kindness and generosity for this program. And then we also use postcard messages to as a form to deliver public health messages that address awareness issues or whatever knowledge gaps over there. And these three elements all serves as a mechanism to engage the community in the process. And in terms of our previous experiences of doing this pay forward research, we had conducted several trials in STI HIV testing among key populations, i.e. gay men in China, as well as to improve influenza vaccination among children and older people. And our previous experiences sort of informed the implementation strategy of the current study. Like, for example, we use the people-centered design, and we try to adapt the contextual components for the current study, and we also use our experiences to inform the engagement strategies as well as the donation strategies, because we have a component of encouraging participants to donate to the initial pool. So we run through several rounds of adaptations actually. So it's a really iterative process, and there are many baby steps along the whole process. And the major first round of adaptation occurred in the early January last year. So we took our previous pay-for materials and invite community members to design the postcards and recruitment posters, as well as key messages to be used in the program. And then we take these materials for a feasibility pilot test. And we try to understand the feasibility, acceptability, and user journeys, whether there are any implementation barriers across the process. And we try to understand the contextual backgrounds better by doing this pilot study. So after this pilot, we get to know that there is actually a pretty poor public awareness of what are the actual differences in HPV vaccine effects in cervical cancer prevention among different types of HPV vaccines, because in the Chinese market, we have quadrivalent, bivalent, quadrivalent, and 9-valent HPV vaccines, but people don't know the exact differences. And also there is a severe insufficient supply of quadrivalent 9-valent HPV vaccine. Most of them are imported only. And there is a delayed hexagon use of bivalent HPV vaccine, mostly domestically produced. And also we identify many implementation strategies, and then we take this data to inform our second round of implementation refinement, adaptation. So we use the co-design with multiple stakeholder groups, like female college students, caregivers, and frontline healthcare workers. And we used, we organized a couple of advisory committee meetings and focus group discussions, individual interviews with all the stakeholders to help us refine the postcard messages. So these couple of postcard messages are sort of refined and are quite different from what I've shown you just a little bit earlier. And we refine the donation strategies, implementation process based on our previous pilot data. So, and after refining all these strategies, we used the 2-arm randomized control trial to assess the effectiveness of this refined, adapted pay-for strategy for improving HPV vaccination among the key population. So basically, we provided very small subsidy to participants rather than covering the complete schedule of the HPV vaccination for the target age group, we provided only 1/3 of the cost, and then we provided so basically only available products are provided to participants, which is bivalent HPV vaccinations, and postcard messages are refined for the formal trial. And then the data have shown us that the refined and adapted pay-it-forward strategy works pretty well in terms of promoting the uptake rate. So we have a significantly higher uptake rate in the pay-it-forward at around 33%, and this compared to only like 18 or 17 to 18% in the self-paid vaccination group. And by looking at the vaccine uptake by study site and sex, we observed significantly bigger differences between both arms, between the two arms among economically better developed areas. And the effect is significantly better among female guardians who received the intervention. And the male guardians, we did not observe any difference, probably because of a very small sample size, and this will need further research. And in terms of donations, among the 53 participants who received the vaccination, 72% of them donated something, and the total donation accounted for around 13% of the subsidies we provided to the participants. And also 41% of the participants wrote a postcard for future people to encourage them to receive a vaccination. And also we looked at the donations by study site, and it's not unexpected that the economically better developed areas, the participants have significantly better donation behavior, as well as higher mean donation compared to the less developed areas. And in terms of the cost per person vaccinated, the pay-it-forward approach has a significantly lower cost per person vaccinated. So in summary, the key findings are the adapted pay-it-forward approach increased HPV vaccination, and we probably can also lower the cost per person vaccinated. And we observed a lot of contagious kindness going on within the community, as long as we provide a mechanism to encourage this to happen. And the results also varies by economic conditions of the areas that we conducted the study. And probably there are also some differences among different sects of the guardians, but we need to look into a little bit further in terms of whether there are no differences among male guardians by increasing the sample size. And the implementation strategy or implementation challenges we identify throughout the whole process can also have implications for future scale up and adaptation or replication in other areas that may have similar problems. Like for example, we had local epidemics happening throughout the process, and which prevent us or at least delayed us in sort of implementing the trial. And boarding school kids, conflicts with the clinical work time, etc., etc. So, and thanks everyone for your attention. I'll stop here.
Great. So I think we have maybe time for one clarifying question, then we'll move on to the next speaker. Any takers? Going once, going twice. All right, if not, we will. Oh, I see a hand from Ashish.
I was just curious, there are various strains of HPV. I was curious, in China, does it follow, there are like 41 and so on, and some of them are more virulent than others. So I was just curious, which are the ones which are more prevalent in China?
The streams, the most prevalent streams are HPV 16 and 18. So those two streams accounts for around more than 50% of the patients who are living with HPV.
Great. Thank you. Over to Dr. Sikazwe.
Hi, Elvin. I hope you can see my screen and that I'm clear and audible.
Yes.
Good, thank you. So thank you for inviting me to be part of this session. And I'll be talking about our program science cycle and the lessons that we've learned from CIDES, the group that I lead here in Lusaka, Zambia. So a little bit of background in terms of who we are. CIDES is really an engine of innovation in terms of partnering with our government in service delivery. We're the largest independent health research nonprofit organization here in Zambia and have been an active partner and collaborator to our government since 2001. We were founded as a collaboration between the University of Alabama at Birmingham, the Zambian Ministry of Health, as well as the University of Zambia. And from 2011, we were incorporated as an independent Zambian organization with majority Zambian leadership. And just in 2020, we launched our 5-year strategic plan, which focuses on diversification of our funding base, broader research agenda, which includes basic science research, as well as looking into our long-term sustainability. So I want to center our talk around the CIDES approach in terms of how we do business. We've really leveraged off our large PEPFAR-funded program that's been in existence since 2004. So CIDES works primarily within public health facilities run by the Ministry of Health. So we do not have any CIDES-specific health centers or facilities. And we have this virtuous cycle that we call our program science cycle, and we can start from our robust program implementation. So as we implement our HIV and TB programming, we're able to work with government and identify relevant questions in terms that are needed to improve the implementation. And through that method, we're able to introduce either innovation or evidence-based practice into the way implementation of HIV services are being conducted. And we embed these into the already existing data collection tools and make them more robust and use our data system to inform the programming. So essentially improving on the monitoring and evaluation of the program and how to improve it. We do undertake rigorous measurements and evaluation, either through nested data collection or nested research studies and laboratory assessments, and translate that into new knowledge that feeds into a government policy. And I'm proud to say also feeds into normative policy from WHO and others, and is used across the region and globally. And this goes right back into the robust program implementation. So our impact for 2022, I've just highlighted what we did around cervical cancer. And this is, we screened with government over close to 55,000 women for cervical cancer in the last fiscal year. So I'll spend the next section of my talk talking about our 20 years of the cervical cancer program. So essentially, it's really been in the making for the last 20 years. And the pictures shown here are pictures taken from women that come to our screening sites, taken by our nurse providers, who are the foot soldiers and the brains behind the cervical cancer screening program in the country. So Dan really did a good job of talking about HIV, about cervical cancer and its high rates globally. In Zambia, Zambia is rated as the third highest rate of cervical cancer globally, and accounts for about 65.5 cases per 100,000 women, and is responsible for 43.4 deaths per 100,000 women, and is responsible for about 23% of all cancers in Zambia. The HIV prevalence is also pretty high. These are results from our last population health impact, HIV impact assessment that was just announced last year. Our prevalence ranges from anything from 5.3 to about 14.4, depending on where you are in the country. In my city here in Lusaka, the prevalence can be as high as 14.4. And we do know that HIV is associated with much higher incidence and rapid progression and increased recurrence of HIV-associated cervical pathology. So my group, way back in 2004, working off the HIV program in the public health sector, undertook this prevalence study to understand the cervical cytological abnormalities within these public health facilities in Lusaka. And they screened about 150 HIV-infected women. And what they showed, or what they found, was that there was really a high prevalence of cervical abnormality. So only 6.7% of the women screened had a normal smear, and the rest, 93%, had abnormal cervical smears or pap smears, with squamous cell carcinoma identified in 20% of these women. So this is back in 2004, before the advent of really wide-scale use of antiretroviral therapy. And from 2006, based on some of those results, the CIDES team with the Ministry of Health piloted the screen and treat approach, which uses VIA and immediate cryotherapy. And this was nurse-led. So we trained nurses that are usually the workforce that is readily available in the public sector to lead this initiative. We started only in 2 public health facilities in Lusaka province, and the ultimate goal was to expand these services across the country. You can see from this paper published in 2011, the rapid scale up in terms of screening across the different quarters from 2006 to 2010. At the end of last year, we had more than 165 public health facilities across all provinces in the country providing these services. CIDES has been able to train more than 800 providers, and these include medical doctors, nurses, lay providers that support the care continuum. As you can imagine, screening for cervical cancer just doesn't start when a woman walks into your facility, but there's a lot of community mobilization, awareness, and sensitization that needs to be done, all the way to addressing the pathology that you're seeing. We do support a hub and spoke model with referral to higher level of care for more advanced disease. And this includes cryotherapy, surgery, chemotherapy, or radiation therapy. So between 2006 and 2020, CIDES with the Ministry of Health has screened over 700,000 women through these outreach and static sites. These are pictures that I pulled off the WHO website, and I'm happy to say WHO because they really represent our work here in country. And these are ladies or women that assessed services within the public sector with the support of the CIDES model, as well as providers. One talks about how she was lucky to be found with early pathology and got treatment by her nurse and had gone back for review and was told that her screen or cervical screen was not clear. And then on the bottom right is an elderly lady who went in to get tested for HIV services, and she was also advised to get cervical cancer screening by her nurse. So pivoting a little bit to HPV, as Dan talked about, the majority of cervical cancers are driven by HPV infection. And a group within the CIDES team back in 2015 conducted a feasibility study of using PCR platforms to see whether we can use those to screen for HPV. And they were able to show that using the Gene Expert platform, HPV screening within the public sector was feasible and was highly sensitive with moderate specificity. If you look on the right-hand side, you will see that our group also conducted this study cross-sectional study to try and understand what circulating strains of HPV are common here in Zambia. And what they were able to show was that for invasive cervical carcinoma, at least 70% of them either had HPV 16 and or HPV 18. And for carcinoma in situ 2, grade 2 and 3, about 58%, almost 60% of them had either HPV 16 and or 18. And in 2019, working with the government, Ministry of Health, we're able to introduce HPVs with self-collection of the cervical specimen by the women themselves. And we integrated this into the national program. So initially it was a small pilot, a rollout or implementation in a few selected facilities. but with 2019, it became routinized and is part of the national program. And about 14,000 of these tests were conducted soon after rollout into the national program, with 44.3% of the specimens collected showing positivity for HPV-16 and or 18. And then when it comes to HPV virus vaccination, we did conduct pilot phase of rollout of the HPV vaccine. This has been supported by multilateral partners such as Gavi and UNICEF supporting the commodities. But we worked with the Ministry of Health to roll out or to introduce this vaccine in Lusaka province. Specifically, what we did was supported the health system strengthening activities for introduction of the vaccine, developed training materials, as well as information guides, did a lot of the training of public healthcare workers, community sensitization, and we targeted about 50,000 girls in 3 districts in the initial pilot phase. There was work done by colleagues from the University of Zambia that looked at the acceptability of the HPV vaccine in schools in Lusaka and the role of the community and formal health system factors that influenced HPV vaccine uptake. And what their findings showed was that there was a lot of community level factors that hindered the uptake of the vaccine, mostly myths around the vaccine. There were stories circulating that this vaccine actually contained the cells that do cause cervical cancer, so that made individuals, parents especially, afraid to let the young girls have this vaccine. And because it was targeting young girls between the ages of 9 and 14, there was misconceptions about it promoting promiscuity, and its influences of religion and other things hindered its uptake. But we've worked with the ministry, and we officially had the HPV vaccine introduced as part of the national program in 2019. And on the top right, we have one of our community champions who is actually a prominent chieftainess in the province. She brought in her granddaughter to show leadership and acceptability of this vaccine, and had her granddaughter vaccinated. So the main enablers for the uptake for this vaccine has really been integration of the vaccine into the national immunization program, as well as government leadership and support, and being able to have adequate commodities and ensuring a constant supply chain. On this last slide, I show you our HPV vaccine coverage over the last 2 to 3 years, and the impact that COVID has had on the uptake of the vaccine. So in 2019, you can see that we started to roll out the vaccine with very good uptake in terms of those that we had targeted for dose 1. There is a drop off in uptake for dose 2, but not too badly. And then we see 2020 and 2021, the steady decline, specifically in 2021, when a lot of vaccine hesitancy was brought about due to the COVID vaccine myth. So there has been quite significant drop-offs there. And we've been doing a lot of community engagements to increase buy-in. We're scheduled to be undertaking an HPV vaccine multi-age cohort drive or strategy starting in September 2023. And we're hoping to do a lot of catch-up for those young girls that missed the vaccine due to whatever circumstances that were going on, and to improve uptake again. I would like to acknowledge the early CIDers pioneers, especially those that were our collaborators from the University of Birmingham in Alabama, as well as the Ministry of Health, for the successes that I've shared with you. Thank you so much.
Thank you so much. That was really amazing to see. And I think we do have some questions coming in, but I think let's save them for the end. There are a number of different questions, both I think about the program and about the epidemiology there. But let's turn it over to Dr. Thomas O'Denny, and then we can loop back and answer these questions all at once. Over to you, Thomas.
Thanks so much, Elvin, and thank you to NCI CGH for putting this together. Thanks to Dr. Ginsberg for really setting the stage with that excellent presentation at the beginning. So we'll be talking about our experience with text messaging to improve retention in care for HIV. And really we see this as giving a flavor for what's possible in improving retention for cancer care with interventions that already exist and have been shown in rigorous trials to work and that are potentially ready for prime time in the cancer control arena. So I'll just go through some motivating examples to address retention gaps in HIV, and then discuss a roadmap for approaching an implementation problem scientifically. Then we can discuss, how this could be adopted in cancer care. So as we know, there are potentially very many interventions and strategies for HIV care that could be tested and applied for cancer control. But the question we might have is whether interventions to improve retention in HIV care, which have been conceptualized within implementation science frameworks, can be implemented effectively for cancer follow-up, especially in low and middle income countries. So I'll give an example of an intervention to improve retention in HIV care that we conceptualized within an implementation science framework and how we could potentially adapt it for cancer control and cancer follow-up in low and middle income countries. So just a brief background about the cascade of care for prevention of mother-to-child transmission of HIV. We know that this is complex, due to the different and changing needs of both the woman and her infant at each step, from ART for a pregnant woman living with HIV to preventing transmission to her baby and uninfected partner, and then infant HIV testing, and then antiretroviral prophylaxis for her baby after delivery, and thereafter continued lifelong engagement in care and treatment. So we know that this cascade is complex and often precarious, and has resulted in high proportions of loss to follow-up for women living with HIV, especially in Africa. We know that there is emerging evidence that mobile phone technology for health, or mHealth, can play an important role in bridging retention gaps in HIV, especially, and particularly in prevention of mother-to-child transmission. And this evidence is fortified by high coverage and ownership of mobile phones among patients and health workers. For example, one study in Kenya found that all health workers surveyed owned a mobile phone. In addition, that study found that virtually all health workers use text messages at some point in carrying out their work. And moreover, we know that there has been a spectacular increase in the number of mobile phone connections in Africa. For example, in Kenya, a country of about 47 million people, there are currently more than 60 million active mobile phone subscriptions, which represents more than 100% of the population. And so a few years ago, we wanted to leverage this impressive access to mobile phones to develop an intervention to improve retention in HIV care for women living with HIV and their children. And so we used qualitative research methods and designed a theory-based, individually tailored two-way text messaging system. And we tested it in a randomized trial and showed a significant increase in both maternal retention in HIV care and infant HIV testing. And then we further tested it in a cluster randomized stepwise trial and showed that it was effective under real-world routine care settings. And now this system is currently being used by many implementing partners. So now we know that text messages do have effects in improving retention. The question then here for us is whether to study again these effects on, say, follow-up of cancer care, or whether instead we should be studying how to implement this intervention immediately. As an example, there are parallels between the cascade of care for women living with HIV and the cascade of care for cervical cancer screening. So for example, for cervical cancer screening, eligible women are screened, they receive their results, and then those who screen positive return for treatment, and then all eligible women remain engaged with screening for a prolonged period based on local guidelines. So rather than study the effects of text messaging again, we can instead use concrete research methodologies and tools of implementation science to instead study how to implement this intervention immediately, or sort of to transport it from one disease to another. And so here's an example of a roadmap for approaching this problem of closing gaps in retention scientifically, and how we could implement SMS interventions to improve follow-up for cancer, similar to what's been done for HIV. So first, we would quantify the gap between evidence and practice, and then we would analyze the reasons for the gap. And then finally, we would conceptualize an implementation strategy. So here's how we are applying this paradigm for improving retention in HIV care, and how we are thinking about drawing parallels and using it to address retention in the cascade of cervical cancer screening. So in the HIV case, we looked at both the published literature and real-world program data to establish the size of the gap, specifically in Western Kenya, where the prevalence of HIV is highest. We have just recently collected similar data from literature review and real-world program data to establish the size of the gap for cervical cancer screening in the same region in Western Kenya. We found that overall uptake of cervical cancer screening programs is low at about 35%. Of those screened, an estimated 25% do not follow up to receive results, leaving about 26% of the original population. And then among those who screen positive, only about 20% have documented follow-up for treatment. And we do not know the proportion that remains engaged in prevention with screening as recommended based on their risk profile. And so this analysis for cervical cancer shows that our populations have not fully benefited from the fruits of biomedical research, including research for improving retention in HIV care that was done right there in that region of Western Kenya. So having quantified the gap, we next need to analyze reasons for this gap between evidence and practice, and then conceptualize an implementation strategy. So to analyze the reasons, one needs to use implementation science frameworks, models, and theories. And these help to ensure that we have considered the problem comprehensively and deeply. And they also help us to explain the reasons for the gap, and also inform development of strategies to close the gap. Now, a detailed description of these frameworks and theories is beyond the scope of this talk, but here is a brief example of how we could use or apply Rogers' diffusion of innovations theory. So in the case of text messaging, what if we know that nothing has been done to implement an intervention like text messaging for cancer follow-up? How do we kickstart it? One way would be to target the innovators, or say if 50% of people, whether that's health workers or facilities, are doing it, then we could try and hit the early majority. And so using this diffusion of innovations theory helps to add a layer of information to the gap. For mobile phone text messaging, this might mean that the technology has been spreading, but the applications of the technology have not. And so this theory might help us determine some of the reasons why. And one practical approach to identifying innovators and applying this diffusion of innovations theory is to analyze networks of influence. And here's an example where we applied sociometric mapping to determine gatekeepers of new interventions. And so this approach uses network methodology to sort of open the door for empirically based network strategies. So if we want to spread a novel intervention, this approach helps us know who to approach to open the door for that intervention. And this can be done rapidly and repeatedly regardless of where we are, and can be done whenever we are considering implementing a text messaging intervention to improve follow-up, whether that's for cancer or for HIV. And there are many other examples of interventions for improving retention in HIV care that can be applied throughout the continuum of cancer care, from screening through survivorship in low and middle income countries. By using the lens of implementation science, we can implement these interventions and strategies now and learn how to implement them rather than conceptualizing interventions from scratch and then showing efficacy and losing time. And we are hoping that this is just a flavor for what else can be transported from HIV to cancer care. So thank you again for this opportunity and acknowledging colleagues and collaborators in this work. Thanks.
Wonderful. This was a great set of talks, and I've taken many notes. I also see many comments and questions in the chat. I think we have a good 20 minutes to get into some of this discussion. So perhaps without further ado, we can start with maybe grouping some of them for each of the participants, and then maybe asking some that are cross-cutting. Let's go back to Dr. Dan Wu's presentation briefly. I see that Dr. Chemtai Mungo has posted a question, and maybe Chemtai, I'll hand it over to you to maybe make a quick comment and see if we can get Dr. Wu's thoughts on you.
Yeah, thank you, Dr. Gang. So my name is Chemtai Mungo. I work in cervical cancer, primarily in Kenya, but also in Malawi. So I really like the concept of paying it forward, and in the African context, it speaks to some of the communal kind of bonds that could be leveraged in HPV vaccination, for example, which is low. But thinking about rural contexts where we work, where, seeing, in your presentation, Dr. Wood, I think the average amount paid forward was almost $300, which is really high in places we work where, people oftentimes make less than $1 a day. So I wonder how applicable that is in places that are lower income, where folks are struggling to provide day to day, and perhaps it could be ways to adapt that in different socioeconomic areas. I'd love to hear your thoughts. Thank you.
Thank you. That's a great question, and the recoupability in other low-income settings, and I understand that there the many financial constraints in these settings, and actually we for our study sites we also included study sites with different economic conditions. Like we have so from the city we included study sites from the highest income level quarter, middle, a higher middle income and lower middle income, and the lowest income level, comparing the whole city economic conditions. And we also provided a sort of adapted subsidy based on what we can offer. So from the provider perspective, it's more realistic to think of what we can actually provide rather than provide to the maximum amount in order to just boost the effects. And we so the price of a domestic bivalent HPV vaccine is around $48 in the Chinese setting, and this is a lot cheaper and more affordable compared to the imported vaccines, and that's what we provided. It's only the price or cost that is equivalent to one shot of bivalent HPV vaccine in our project. So we leverage this opportunity to also to engage them in the project, and also this gives us an opportunity to give them the educational messages that they do not seem to be commonly receiving from the market or from the government. So I think this is a mix of factors that have been helping us to achieve such an effect. And the generalizability to other low income settings. And I've learned from from Alvin and Thomas that there is a strong giving culture in Kenya or maybe in other African countries. And I think this is a natural, solid for implementing or at least experimenting this concept in other low income countries. And I believe that no one would not love human kindness, So I think this is there are a lot of opportunity to try that out, and it would be really interesting to also see how this might work in other places. I hope that answers the question.
Yeah, thank you so much, and I'll reach out separately. Thank you.
Great. We have a lot of questions, so I want to spread them out among the speakers. I'm going to ask Basisla to make a comment. He or she has a note here directed at Dr. Sikazwe, and it sounds like might be a point of departure for a comment or a question. Over to you. If the audio there isn't working well, happy to direct another question to Dr. Sikazwe from Pauline. Maybe over to you. Give you one moment.
Hello. Bonjour. Hello. It was a question about the study in cervical cancer in Zambia. And I, at some point in the presentation, you talk about the self-collection of samples for screening of cervical cancer. And so I was wondering how these samples are actually managed, because is it done in a public health facility or is it done at home by the patient herself? And if so, what is the reach of these self-collection samples? How the women manage to send it back, and how do they do to get the kits and everything? And another question was also about how often are women screened for the cervical cancer with the program?
All right, so I'll try and respond to both of those. So thanks for that question. So for the self-collection kits, what they do is distribute them at the health facility or in other community settings, and women are taught how to collect the samples. The kit actually is self-explanatory. It has pictures, so it doesn't have to, it's not dependent on your literacy level, because it has pictures that explains exactly how to collect that sample and when to collect it and how to keep the specimens, and then you send them back to the health facility. So there is a drop-off in terms of how many samples are distributed and how many we get back into the lab for testing. And if your screening test is negative, then you're asked to come back, I think, in 6 months' time for another review. But if your screening is positive, what we do is schedule you in within the next 2 weeks of getting that result back to go to a health facility and have one of the nurses do an actual physical check. So using the screen and treat methodology to actually visualize the cervix. It's a pretty easy procedure in terms of the self-collections. There's been pretty decent uptake. Even here at the office, we do sometimes distribute those self-collection specimens. And then the screening for cervical cancer, it's dependent on what your HIV status is. I'm going to get this wrong because the guidelines are quite specific in terms of if you screen negative and are HIV positive, I think you have to come back for a rescreen in 2 years. And if you're HIV negative, you may have to come back after 3 years. But please don't quote me on that because I get the timing off. But there are guidelines in terms of when you come back for screening, depending on what your HIV status is and what your screening test looks like.
Great, thanks. I hope that addressed your question.
Thank you very much.
Again, we have some
Yes.
chats
Thank
here. I encourage the panelists to maybe type in quick ones for ones that are easily answered. I'm going to channel Vidya here in the last question directed at Dr. O'Denny, and going to ask you to comment a little bit about sustainability. So in terms of SMS messaging for retention and for other HIV services, it's had a really interesting trajectory over the last 10 years, from starting with research studies to at this point being used somewhat routinely in many program settings. Probably not every single person, but has been widely adopted. And maybe could you comment a little bit about your view on the trajectory of SMS messaging as an adjunct for treatment in HIV, and how it's grown and what factors have helped it to scale and become a what appears to be a sustainable piece of programming at this point. But maybe you could comment on that briefly.
Yeah, thanks, Alvin. I think for SMS and text messaging, a lot of it I think is serendipitous, in the sense that this was a technology, I think, for I can speak for Kenya, in Kenya, whose time had come, and sort of it's ubiquitous. It's used in banking, in all sorts of commerce, in farming, and I think it was only a matter of time before it became part and parcel of delivering healthcare. And so I think for us as scientists, the question was how to incorporate it, scientifically, and in a way that maximizes the effects and minimizes adverse effects. Because one thing we don't talk about is there are adverse effects from some of these interventions, and I think there are unique ways with technology to minimize those kinds of effects and maximize success. I think for me, SMS is an idea in the sense that it opens the door for us to think about technologies that are being used in everyday life and how we can leverage those for clinical care. I think it's along the same lines as what Dan is doing. So she's talked about kindness and generosity being contagious, and a country like Kenya being highly generous on international scales. So these are things that already happen, and I think our job might be to think about those and how we could bring them into healthcare and leverage them. And then we don't really worry about sustainability so much, because they are sort of self-propelling, so to speak. Thanks.
Great. So I think, again, lots of questions here. Perhaps we'll take a big picture question that each of the panelists might respond to. I'm going to hand this over to Abdo. Please forgive me for pronouncing your name incorrectly. Azuri, who has posted a number of questions, but the last one I think might be food for thought for all of us. So over to Abdo, if you are available. Okay, if that isn't gonna work, that's fine. I know we have tech issues.
Oui, allô, oui, ça va.
Oh,
Oui, j'ai bien activé le micro.
Got it. We hear you. Please go ahead.
Par rapport à ma question, c'est ça?
Oh, I was just mentioning that you had posted a couple of questions for the group, and I thought we could turn it over to you to pose one of them for a little bit of discussion.
Ok, merci bien. En fait, ma question est relative au fait qu'aujourd'hui, le cancer, surtout dans les pays sous-développés comme le Burkina, la prévalence est en train d'augmenter. Est-ce qu'à l'image du VIH, est-ce qu'on ne pourra pas avoir un organisme, en fait, ou bien la lutte contre le cancer, là, est-ce qu'on ne pourrait pas faire à l'image du VIH où ce sont les présidences des républiques qui avaient pris ça comme leur activité? Voilà, est-ce qu'on ne va pas faire ça? Est-ce qu'on ne peut pas avoir un plaidoyer international pour que vraiment les États puissent prendre la lutte contre le cancer comme à l'image du VIH?
So I am just being alerted to the translational issues, but thank you very much for posing that question. I believe for the panelists, the question is also in the chat, so it's the last one there, and maybe folks could speak to that issue. Any takers?
Just very briefly, I think that's a great question, and I think speaks to the global response. Maybe that would be a question for NCI about ways of funding or consolidating funding similar to what we did for HIV, where we had PEPFAR, the Global Fund, and WHO, and then mechanisms at the country level to sort of bring everyone together on board. I think we are beginning to see that, of course, with the caution that we do not want to create siloed systems. I think the opportunity we have here is to learn from the good things that worked for HIV and not create another silo of cancer care. But I think that's great for us to begin thinking about financing at a global level, maybe achieving a PEPFAR-like response. But over to Dr. Sikazu and Dr. Wu.
No, I think, Thomas, you responded adequately, and there are lots of lessons from HIV that can easily be translated to other diseases, including cancers, from the funding perspective, from the implementation of community engagement strategies, even from diagnostics and how to better leverage some of the diagnostics that are already in place and use them for multiple diseases. So I think it's going to take leadership and advocacy to make that happen and move away from the siloed approach of how we've done business.
Great.
Thanks. I just want to add one minor point, because if you asked me the question like 10 years ago or 20 years ago, it would probably very hard to respond. But because of the advancement of medicine and evidence that we're accumulating, that at least the cervical cancer, for example, or some of the liver cancers are actually preventable at the moment. So I think there are a lot more things we can do in terms of taking this into the global level, and if we can do more to take these preventive efforts starting from the very earlier care continuum. And I think many of this can be achieved, or at least by baby steps, we can do a lot more than we think. Thank you.
Great, fantastic. I think lots of discussion, perhaps to continue after the session. I think there's just maybe 1 or 2 minutes left. And just to close out, I'm going to take the chair's prerogative and ask each of the speakers to answer one question in 15 or 20 seconds. So the question is, if you have one word of advice for global leadership about cancer control in the next 10 years, what would it be? Briefly, quickly, Thomas.
Funding. I think funding. Put your money where your mouth is. Just increase funding for cancer control.
Great. Zuzu.
That's a tough one. I think funding for sure, but also community advocacy, because our leaders only seem to respond when communities advocate and press them in a corner. So advocacy.
Fantastic. And Dan.
I would say capacity building and train the trainers would be very essential.
Fabulous. Well, thank you everybody for a phenomenal session, a tremendous set of presentations and discussion, and food for thought going into the future. I'm going to hand it back over to Mishka, and over to you. Thanks everybody for your questions and participation.
Thank you.
Wow. Thank you, everyone. That was a really fantastic session. And there was a lot covered. Thank you, Dr. Gang, and for all of the panelists, and for all the participants and all of your questions and comments in the chat and everything. As you can see, there was a lot covered, a lot started. So do encourage you all to stay in touch with each other, stay in touch with us. I'll put my email in the chat if those of you who want to connect with the panelists, connect with each other after this, continue the dialogue going. We're happy to try to make some connections if and where relevant. So please stay in touch with us. So now, however, I'm excited to welcome you to join us for the next session, which is the Meet the Abstract Authors poster session. So in this session, you're actually going to have the chance to meet authors of nearly 100 scientific posters, and they represent programs and research that span the cancer continuum and also are conducted in 6 world regions. So get ready for some interaction now from all of you. So this poster session is taking place on a platform called Gather. You can access the Gather platform using the link in the chat. Now you can keep the Zoom window open and navigate to Gather. We do ask you to come back into Zoom after the session itself. You see the QR code here on the right. That is the access to the Gather guide, and that gives you information about navigating the platform, as well as the listing of all the scientific posters that you will find there. And then you can also, once you're in the platform itself, there are materials stations, and you can access the Gather guide there as well. Now, if you're looking for a specific poster, you can find them numbered both on the ASGCR event site, as well as in the scientific poster listing. And Dave is posting some of those links for you in the chat right now. So we welcome you to navigate over there. The poster presenters, if any of you are here now, please go to Gather now. Go stand by your poster, stand in air quotes, by your poster, and please welcome everyone to interact with each other over there. Then once the Gather session is completed, please come back to the Zoom meeting, and we will pick up with the oral abstract flash talk session at 11 a.m. Eastern time. We will be making an announcement within the Gather platform when it's time for you to return to Zoom. So please enjoy meeting the authors, and we will see you back here soon. All right, welcome back, everyone. I think people are slowly returning, hopefully, from the Gather Meet the Abstract Authors session. I'm just going to see if the numbers start to tick back up again. I understand that some folks left Zoom and are coming back, so thank you all for navigating this newer technology and trying to create an interactive poster session. And I'm going to go ahead and get started here. We are very happy to introduce the oral abstract flash talk session for today. And I hope you all had some of the really great engaging interactions during the Meet the Abstract Authors session, and you'll have a chance again to do this tomorrow. You'll also be able to see all the posters on the event site. We can repost all of that in the chat as well, so that you can stay in touch with these abstract authors. So it's time now to turn our attention to the oral abstract flash talk session. And for that, I'm turning things over to one of our longest serving ASGCR steering committee members, representing the American Society of Clinical Oncology's Academic Global Oncology Task Force, Dr. Maria Teresa Burlón of the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Zubirán and Universidad Nacional Autónoma de México. Dr. Burlón, over to you.
Thank you very much. I want to welcome everybody to this very interesting oral abstract flash talk session. I'm very happy to chair this session today, and I'm happy to introduce my co-chair, Dr. Hawa Kamara. Dr. Hawa Kamara is at the National Institute of Cancer in Rockville, USA. She's a cancer prevention fellow at the Center of Global Health. The purpose of this session is really to provide an opportunity for a diversity of researchers to present and disseminate their global cancer work to pertinent stakeholders. This has become a fundamental piece of each annual meeting of the ASGCR. There are 10 oral abstracts presentations we have selected for today. This was a peer review process based overall on the score and relevance to priority topic areas and the symposium theme. Presentations have been grouped by topic area following the cancer control continuum. I would really like to acknowledge the overall strength of the submitted abstract this year. We would like to invite you to view the other 90 abstracts on our website and in the poster session tomorrow. Abstracts will also appear in a special issue of the AACR's Cancer Epidemiology, Biomarker, and Prevention this June. Now, we would like to present high-level rapid-fire presentations. During this time, we would have a rapid explanation of the study. Additional information or details related to the presentations will be available on the poster presentations. We would like to remind you that we will not have a question and answer session or discussion. Instead, we would like to invite you to please join tomorrow's interactive poster session on Gather platform. You can find the full list of accepted abstracts on the events webpage under the poster tab. To link to the posters you can find in the chat, so we will post that there, so you can find all the accepted abstracts for this symposium. I'm very happy to turn over to Dr. Hawa Kamara in order to start the presentations of our speakers today. Thank you very much for joining us. Dr. Hawa Kamara, please.
Thank you very much, Dr. Bourlon. Good morning, good afternoon, good evening, everyone. I will be introducing the first topic, which is on prevention and early detection, diagnosis, and prognosis. We will have 5 presentations in each of the topic areas. So I will be introducing the first speaker, and this is Dr. Rita Josiane Nguese from Scale Up Cervical Cancer Elimination with Secondary Prevention Strategy Success, Jepaico, Côte d'Ivoire. Dr. Nguese, I turn it over to you.
Hello, everyone. Did you see, I don't know if I share my screen. Okay, perfect.
Yes.
So thank you. Hi, everyone. So I'm Rita Nguese from Côte d'Ivoire, and I'm going to talk about human papillomavirus and cervical cancer screening in Côte d'Ivoire. Slide, please. So cervical cancer is caused by infection with human papillomavirus or HPV. This infection is usually transitory, but in some cases it can persist and evolve into precancerous lesion, which when are not treated, they can evolve into cancer. And it usually takes more than 10 years from infection to cancer, which makes this disease to be easily preventable and curable. Despite this, cervical cancer is one of the most prevalent cancer in low and middle income countries, and is still the second deadliest cancer in women in Côte d'Ivoire. Can you move on, please? Thanks. So it is to address this public health problem that WHO has called for action in 2019 and asked countries to eliminate cervical cancer by ensuring that young girls are fully vaccinated against HPV, that the women are tested for HPV, and that most of the positive women are treated, receive adequate treatment. Can you move on, please? And it is to respond to this call that the Scale Up Cervical Cancer with Secondary Prevention Strategy or SUCCESS project was born. SUCCESS aims to screen and treat precancerous lesion in women in 4 countries, which are Burkina Faso, Guatemala, Philippines, and Côte d'Ivoire. And to do that, SUCCESS has introduced HPV-based cervical cancer screening and treatment with ablative methods. And one of the first goals of SUCCESS is a research goal, and it aims to generate significant evidence on the feasibility, acceptability, and the cost of introducing such new approaches into existing health services. For the methodology, women attending the health facilities were being offered the choice to be screened either by self-collection or by the provider sampling. After sampling, the sample was transported to the lab for analysis, and when available at the facility, it was announced to the woman. Can you move on, please? No, yes, thanks. It was announced to the woman. When the result is negative, the woman just has she's consulted and has a follow-up appointment 5 years later. But when the HPV test is positive, the woman has to undergo visual inspection of the cervix, which is called also VIA. And here you can see when there's no lesion, the cervix is beautiful and is pink, and the woman has a follow-up appointment the year after. But when there's a lesion, you can see here there's a whitish spot. So the woman received treatment and she's followed. She has a follow-up appointment the year after. So for the purposes of the study, we enrolled women aged 25 to 49 years after HPV testing in 10 facilities from April to November 2022. And each woman were followed up during all this process to document this continuum. And in addition to the research question that I talked about before, we also wanted to document the factor that could influence VIA completion after a positive HPV test. For the result, by the time of analysis, we had 1,868 women enrolled in the study, and the majority of them, which was 92% of them, chose self-collection at the sampling method. There were only 948 results available at the health facility, and merely 25% of them were available within 30 days, while the majority of them were available after 60 days. When we looked at the time, the turnaround time for cervical cancer services, which is the next one. Thank you. So we saw that the average time from sampling to result reception was 61 days. There was 27 days from result reception to VIA completion, and the overall time from sampling to treatment was 70 days, which is very, very long. And we wanted to see which factors could influence VIA completion. And we saw that compared to a testing to result time, which is within 30 days, when we have more than 30 days, between 30 to 60 days or more than 30 days, it decreased the likelihood to perform VIA in women. So based on this, our first preliminary results indicate that HPV-based cervical cancer screening is acceptable in Côte d'Ivoire with a marked preference for self-collection. However, there's a very long time, turnaround time for result reception, for result announcement to women, and also for VIA completion. And this negatively impacts the time to treatment. So our recommendation for the MOH and for the technical components of success is to, the next one, please. Thank you. It is to increase lab coverage while making sure that the lab are close enough from the screening sites to closely monitor laboratory activity, which is really a core component of the continuum. And they should also improve client follow-up, for example, by using community health workers. We can go to the community and help catch up these women that are lost to follow up. So it is with this that I'd like to finish. I thank everyone. I thank the organizing committee, the success partners, and the sponsors. Thank you.
Hi, shall I start straight away? Oh, I'm sorry. Yes, I'm muting myself. Okay. Can everyone hear me?
Yes.
Okay, perfect. So my name is Tan, and I am going to talk about the paper, multi-level barriers and facilitators of smoking cessation among people living with HIV in Vietnam. And this is a qualitative analysis. Yeah, please, can I have me to move on? Yeah, thank you. A little bit about the background. So tobacco smoking is highly prevalent among people with HIV, and especially in low-middle income countries. The prevalence in Vietnam is about 60%. And there are interventions for this group that showed positive results in high-income countries. However, such interventions are not prioritized and still lacking in Vietnam. So in order to strengthen implementation strategies of potential smoking cessation interventions, it's very important to understand the smoking behavior characteristics of this group. So that's the reason why we aim to explore barriers or facilitators of smoking cessation of those receiving HIV care in Vietnam. This one, thank you. Okay, so this graph illustrates the whole study protocol, including the methods. So we recruited participants at 3 outpatient clinics and conducted in-depth interviews with 24 patients, as well as 13 providers. The interview guide and analysis was guided by theoretical domain framework, TDF. 2 coders, including me, analyzed the data in last year using the 2-step abductive thematic analysis approach. Firstly, we deductively identify barriers and facilitators at different levels, including individual, provider, and system level. Then we conducted inductive thematic analysis to develop themes, explain themes, as well as to explain the relationship among the themes. Please move on to the results slides. Thank you. Here comes the results. For barriers, the barriers include that patients who lack knowledge and misperceived about smoking harms, as well as smoking cessation aids, exposure to smoking environments and stressors. Providers lack skills and knowledge to assess as well as to provide tobacco use treatment. And at system level, there's a lack of screening and interventions. For facilitators, most patients report that self-determination was the main reason for them to quit, and it can be enhanced by worries about health and pressure to quit from family and society. At provider level, providers' optimism and positive perceived role in providing tobacco use treatment, as well as the trusting relationship with patients or the facilitators. And at system level, facilitators are training, financial, and personnel support. These barriers and facilitators were classified into relevant TDF domains, including knowledge, social influences, environmental context and resources, and motivation and goals. The relationship between them is presented in the figure to the right, as you can see. And from the thematic analysis, motivation and goal is the major facilitator of smoking cessation that can be influenced by the other TDF domains. Yeah, please move on. Thank you. So to conclude, our study indicates that smoking cessation intervention at different levels could strengthen patient engagement in tobacco use treatment intervention. And this is very important for healthcare providers to receive training to deliver tobacco use treatment, as well as to educate patients about health impact of tobacco use. Finally, system changes are needed to integrate tobacco use treatment into routine care at HIV clinics in Vietnam. Thank you very much. That's my presentation.
Great. Hello. Hi, everyone. By the way, do I just tell people when to advance slides I'll just kind of say
Yes.
next. Okay, great. Thank you. All right. Well, thank you so much for the opportunity to speak today about our work in Bluefields, Nicaragua. My name is Maria Geba. I'm a second-year infectious disease fellow at the University of Virginia. And our presentation today is entitled Collaboratively Adapting a Telebehavioral Mobile Platform to Enhance Patient-Provider Communication Regarding Cervical Cancer Prevention Efforts in Bluefields, Nicaragua. Next. Right, so Nicaragua, pictured here, has the highest rate of cervical cancer in Central America. Can you hit next twice? Thank you. With cervical cancer being the leading cause of cancer death in Nicaraguan women. Next. Our study is based in Bluefields, Nicaragua. Next. It's a rural community along the Caribbean coast that is home to rich ethnic and linguistic diversity. And we have been lucky to collaborate with for many years with SEDECA, pictured here, which is a community development NGO based in Bluefields on this chart. Next. So mobile platform a mobile health platform called Azulado was designed in 2020 to improve engagement, retention, and cervical cancer screening and treatment in Bluefields. This mobile platform was culturally and linguistically created for the women in the region based on patient feedback and was successfully piloted in the summer of 2021. And so current features include daily energy and stress readings, women's testimonies, educational resources about cervical cancer, calendars and notifications, community messaging board, and direct patient messaging to providers. And patient feedback has helped create the current features of the application. However, next we sought to elicit provider perspectives to better build on the current design and help create a patient provider portal for the application. Next. So in the summer of 2022, we traveled back to Nicaragua to conduct a mixed method study consisting of interviews, focus groups, and surveys for a variety of providers in the region, which include those listed here. So dermatologists, psychologists, OBGYN physicians and nurses, oncology nurses, pathologists, IT engineers, and nutritionists. And next. Great. Thank you. Here are some of the results from the Qualtrics surveys that we conducted, which was distributed to 20 participants. We found that the participants rated the app highly and were satisfied with the app, thought it would be helpful for their patients, and found it easy to use. So the results from interviews and focus groups aren't presented here due to time constraints, but briefly, just to kind of mention them, we found that participants valued inclusivity and ethnic representation in the platform, incorporating mental health support for women facing a new diagnosis or abnormal test result, and guaranteeing patient anonymity. That was another important thing for providers, especially in a closer knit community like in Bluefields. Next. And yeah, so thank you so much for listening. We would like to just thank our participants for their time. This project would not have been possible without the support of the Center for Global Health Equity at UVA and for providing funding to travel. And we would like to also especially thank our collaborators in Nicaragua and at SEDECA in particular, Joel Campbell and Earl Taylor, and the entire Azulado app team. Thank you.
Hello, my name is Chihong Chen. I'll just go ahead and start my presentation. Yeah, so today I would like to bring your attention to the East Asia. And I'd like to introduce to you a very common genetic phenomenon that is associated with alcohol drinking and upper aerodigestive tract cancer. And I'd like to present to you a model that we have been doing in Taiwan and East Asia. So I'm from Stanford University. I'm also representing the Asian Health Research and Education Center. Okay, next slide. Yeah, so I'd like to bring your attention to alcohol use. And so alcohol use it's attributed to the global cancer, about 4% of all cancers. are attributed to alcohol drinking. So alcohol drinking incurs a very heavy burden of cancer worldwide. And but however, my attention, a very simple message to you is that many people do not know that alcohol drinking can cause cancer. In fact, a recent study from NCI shows that the majority of US adults do not know that alcohol drinking can cause cancer. So there's a lot of public health awareness education that we need to do in this area. Here on the left shows that that the alcohol drinking is, especially the burden is very heavy in the East Asia. If you compare regions in the world, that East Asia ranks the highest in terms of cancer attributable alcohol drinking. And the color here shows the darker color, the heavier drinking, and you can see that there's a dose dependent on how much alcohol you drink and the risk of having cancer. In the middle, that it shows that alcohol causes 7 very common cancers. This is an informational graph from WHO, shows that 7 types of cancer are directly caused by alcohol drinking, especially the upper aerodigestive tract cancer. That's in the oral region, the neck, head, neck, larynx, pharynx, and the upper esophagus. On the right, I'm showing you that there's a very good correlation that since East Asia has heaviest alcohol attributable cancer, this type of cancer is most serious in the East Asian countries. That is the head neck cancer and esophageal cancer. You see that Eastern Asia is also the region that has the highest incidence and death caused by alcohol drinking in the UADT region. Okay, next slide. And there's a very simple reason of that. Of course, alcohol drinking is the risk factor, but there's another genetic risk factor that's so important. And many people in the East Asian country do not know about this. So my purpose is really to bring the awareness and the lack of awareness to these countries and also East Asian American descent. On the left shows that this common mutation, how it works, because alcohol, it's a group 1 carcinogen that has been classified by WHO many years ago. The metabolite of alcohol showing here, the intermediate metabolite acetaldehyde, is also a group 1 carcinogen. And many people have a mutation in the ALDH2 gene, which causes the alcohol flushing syndrome. Many Asians has that. The symptom is very easy to recognize, alcohol flushing, and they have headache, palpitation, vomiting, so on and so forth. The map shows how common this mutation is. This is probably one of the most functional deficiency in the world. 540 estimated 540 million people have this mutation shown on the map. Range from 30 to 50% in the East Asian country, highest in Taiwan especially. Half of the populations are carrier of this mutation, but many people don't know the meaning or the health consequence of this mutation. On the left bottom shows how dangerous this is, the odds ratio of having cancer with 1 to 3 drinks of beer a day. It's very high, about 80-fold increase. If you see the red line, shows the people who flush and drink 1 or 2 or 3 beers per day. And so we do a lot of education. Next slide. To bring a model to Taiwan, so I started a nonprofit organization called Taiwan Alcohol Intolerance Education Society, mainly to bring awareness to people. We enlisted many volunteers, and we also do public health education in communities and use heavily social medias, and also with government support. Now we promote a National No Alcohol Day. And you can see that there are several tools that we can use. I'm happy to share with that. Last slide. Just want to highlight you with the next slide. Last slide to highlight you a few success. We have used model to test in Taiwan, in college, in communities. We show that this model can actually bring awareness and reduce alcohol drinking, and also to promote No Alcohol Day in Taiwan. Now this is a national day on May 9th, because it's the same pronunciation as No Alcohol Day. And we have tour to share. And I hope you can join this campaign, and more than welcome to have you to share this tours with you. Thank you very much.
Hello, everyone. My name is Varun Nair, and I'm a fifth-year undergraduate student studying genetics and global health through the University of British Columbia's Integrated Sciences program. Today, I'll be sharing a project entitled Understanding the Cervical Cancer Self-Collection Preferences of Women Living in Urban and Rural Rwanda. Before I begin, I would like to recognize the efforts of our collaborators affiliated with the University of Rwanda and the Eagle Research Center, as this project would have been impossible without their contributions. Next slide, please. Cervical cancer is a type of cancer that develops in the cervix and is a major cause of cancer mortality in low and middle income countries, which I'll refer to as LMICs from here on out. With regular screening, such as through pap smears and other testing, it is possible to catch precancerous cells before they develop into cancer. But what happens if cervical cancer is diagnosed late? Well, it can become much more difficult to treat and can even be life-threatening. However, in LMICs, due to the many economic and political barriers that are present, screening programs are often heavily underserviced, underfunded, and underutilized. In fact, many women in LMICs have also been found to not access such forms of formal screening because they find it uncomfortable or embarrassing. Therefore, there is an immense need to develop and implement cervical cancer screening programs in LMICs that can be accessible to and used by as many women as possible. We chose to study this in Rwanda specifically because there is currently no formal screening program in place for cervical cancer in Rwanda, causing it to have dramatically high rates of cervical cancer incidence and mortality. This is where we hope self-collection can come in. Self-collection is a simple and easy way to collect a sample for testing through self-administration at home that is just as effective and much more resource efficient compared to other forms of screening. Previously, our team has conducted various self-collection-based cervical cancer screening initiatives to improve access to reproductive health in Uganda, which serves as the basis for this study and future research in the context of Rwanda from our team as well. Next slide, please. Therefore, this study's objective was to understand and compare the attitudes and preferences of women in urban and rural Rwanda towards self-collection for cervical cancer screening. Local research assistants administered a cross-sectional survey in June 2022, and recruitment took place at 2 hospitals in Kigali and Nyamata. Kigali is Rwanda's capital city, which has a population of about 1.3 million people, and Nyamata, which is a rural district in Rwanda with a population of about 30,000 people. The research assistants verbally administered the survey in either English or Kinyarwanda, both of which are national languages of Rwanda. All data was directly entered into REDCap, which is a data management tool, via electronic tablets. The inclusion criteria was kept purposely broad to capture as representative of a study population as possible, with any women over the age of 18 seeking any form of care being eligible for recruitment. The survey consisted of 52 questions from various sections, such as demographics, knowledge of cervical cancer and screening, barriers to screening, and attitudes towards self-collection. In this study, however, we have chosen to analyze specifically the responses to questions pertaining to women's demographics and self-collection attitudes. For analysis, we used RStudio and reported the data using descriptive statistics. Next slide, please. Among the survey's 374 respondents, the average ages were roughly 33 years across both sites. The majority of respondents at both sites had completed education at the primary school level or less, were in a relationship at the time of survey completion, and had their first intercourse at or above the age of 18. Now, moving on to respondents' preferences towards self-collection, we found that the vast majority of respondents at both sites were open to self-collection, though Nyamata respondents were significantly more amenable in this regard. The majority of respondents also felt unembarrassed about self-collecting, with Nyamata respondents again showing significantly greater amenability. Respondents at both sites were roughly equally unafraid of social stigma surrounding cervical cancer, and overwhelmingly were willing to go to a nearby healthcare center for a pelvic examination if their self-collected results were concerning. Last slide, please. We can ultimately conclude that women in both urban and rural Rwanda show support for self-collection-based cervical cancer screening programs. We hope that this study begins a cycle of future research that investigates the implementation of self-collection for cervical cancer to the existing healthcare infrastructure in Rwanda. From this, gaps in health service delivery can then be identified. For example, 2 intriguing gaps that we found in the study were that there is a notable divide in women's perception of whether or not they needed their partner's approval to participate in self-collection. And we found that this was irrespective of whether they're from urban or rural Rwanda. Additionally, we also found that 53% of Kigali respondents and 76% of Nyamata respondents said that they wouldn't be worried about the pain they felt during the procedure. I'm just now noticing that I hadn't updated these percentages in my slides, so my apologies for that. Nonetheless, this is a very big difference between the 2 sites and warrants further investigation as to why this difference in amenability from the perspective of pain exists. Now, coming back to this cycle, identifying and more importantly, understanding these gaps can then lead to policy changes and program development, which can then be implemented within the Rwandan population. Continued research and development of such programs and policies would further stimulate this cycle, leading to greater access to cervical cancer screening for women in Rwanda. I would like to thank Hallie Dow, a PhD student working in my team, for her invaluable support throughout this project, as well as principal investigators Dr. Gina Ogilvie and Dr. Stephen Rulisa for their expertise and for the opportunity to work on this important endeavor. Please feel free to connect with me via email or LinkedIn to chat further about this project. Thank you for your time.
And we're now moving on to the second topic area, which is treatment and cancer control, survivorship, and outcomes research. Our first speaker under this topic is Dr. Donna Shelley from the New York University School of Global Public Health in New York. Donna, over to you.
Thank you. So thank you for including our work in this set of presentations. My name is Donna Shelley. I'm a professor at NYU School of Global Public Health. And I am collaborating with Nam Nguyen from the Institute for Social and Medical Studies on this study. I'm starting with this slide to orient you to the full design of a study we're conducting in Vietnam before I focus on AIM-1. This is a randomized controlled trial comparing the effectiveness of 3 tobacco cessation interventions delivered by clinicians and staff in HIV clinics in Hanoi. In Arm 1, all patients are screened for tobacco use, provided brief counseling or advice, and referral to the national quit line, which we are calling standard of care. That quit line is not tailored to HIV patients with HIV. Versus the Ask Advise plus this time on-site 6 sessions of intensive counseling tailored to the HIV patients delivered by nurses, and then Arm 3, which includes Arm 2 plus nicotine replacement therapy. We are simultaneously evaluating the effectiveness of strategies to increase adoption of the intervention components by the clinic staff and clinicians. The complexity of transferring an intervention and strategies that were developed in high-income country context to Vietnam require that we adapt the intervention and implementation strategies prior to launching the RCT. This work, as you see, was published already recently in Implementation Science Communication if you want to learn more, or I'm happy to see you tomorrow at the poster session. Next slide. As I noted, the aim was to conduct a systematic process for adapting intervention components. We were guided by the Consolidated Framework for Implementation Research and Theoretical Domains Framework in developing the survey and interview guides. In order to adapt these interventions and strategy components, of course, we needed to specify them, the components. And we were guided by Proctor's recommendations for specifying reporting strategies that we also applied to the intervention components. This included clearly defining the components of the intervention and strategies, who delivers each one, the specific actions involved, how is it delivered, dose, when in the visit is the intervention or strategy applied, the outcomes affected, and the justification for each choice, which was again driven by theory. We conducted surveys, interviews with patients and healthcare workers in 3 clinics to understand the context of tobacco use among these patients, including barriers to quitting. And concurrently, in interviewing the staff and clinicians, we wanted to understand barriers and facilitators to integrating tobacco use treatment in HIV clinics in Vietnam, because they were going to be delivering the intervention. We did workflow mapping in which we met with the clinic staff and clinicians to map current workflows and then asked them to indicate how they would fit tobacco cessation intervention into their workflows, given the specifications of what that entailed. Importantly, we also tested measures of risk perception and healthcare climate, survey tools that have been developed in high-income countries. This was really critical to finalizing the surveys. And we used a pragmatic approach to analyzing the qualitative data. Again, more detail in the paper that we published recently. Next slide. I'm going to focus just on the first 2 columns. This slide and the next are mainly to illustrate the approach in which each intervention component was adapted or not adapted in the terms of the quit line, the justification for the adaptation, which is based on the evidence from the data collection. I'm not showing the specifications, but suffice it to say each component of each arm was adapted based on the data collection, the findings from the data collection. Again, this is the intervention slide. So we focused in this case, in terms of Arm 1, on adapting and Arm 2, the counseling, intensive counseling and brief counseling to address specific effects of HIV on tobacco use and the social cultural context of smoking among HIV patients in Vietnam, which is different than it is in the US and other high-income countries. Notably, that there is a high prevalence of dual use with water pipe, which required adding content related to this form of tobacco use. Again, the quit line is standard of care, so not tailored to HIV patients. In the next slide, you see the implementation strategies on the left that included training and clinical decision support, workflow and redesign to help a system for referring patients to the quit line and documentation systems to help clinics track treatment and NRT distribution. Each of these was mapped to potential barriers clinics might experience in implementing tobacco use treatment, the intervention, with the main goal of increasing adoption and fidelity to the treatment protocols in each arm. Again, we modified these to address HIV referent themes in terms of the provider training curriculum and coaching guide. We also created with the clinic and national quit line a method for referring patients to the quit line. And again, the documentation systems were aimed at increasing fidelity to new workflows. Next slide, final slide. So in conclusion, it may seem obvious, but I think a lot of times we understand that transferring evidence generated in one context to another requires adaptation. But it can be an intensive process, but I think what we demonstrated was it can be feasible if you balance pragmatism and rigor and use a rapid analysis process and multiple methods to gather the data. Using theory to guide the systematic process provides strong justification for each of the adaptations and increases potential for generalizing to other sites. And of course, deferring to country partners' expertise and including them not only as subjects, but as partners in the adaptation process was critical for effective adaptation and implementation. We are in the field right now and things are actually going relatively well. We did have to make some further adaptations at the very beginning. We did do, just one more point, we did do a pilot study before we launched as well after making those adaptations. I want to thank again the clinic staff in Hanoi and all of my partners at the Institute for Social Medical Studies and at Hanoi University of Public Health who is doing the cost analysis on this project. Thank you.
Sorry, you're muted. Oh, okay. Good morning. Sorry, I was waiting for the introduction. So thank you so much for giving us the opportunity to share our research project with you this morning. My name is Ayasame Falade. I'm an internal medicine resident at Mass General Brigham Salem Hospital here in Massachusetts. I would like to acknowledge the contribution of Dr. Adeoye Oluwatayo to this project, and also the immense contribution, guidance, and mentorship of Dr. Geoffrey Buckle. This research project, I will try to highlight the points on each slide because we have a lot of information. The topic will be clinical trials in gastroesophageal cancers and analysis of the global landscape of interventional trials from clinicaltrials.gov. Next slide. So I would like to point out, this is a database analysis. And the reason why we're doing this is because gastroesophageal malignancy is one of the leading causes of cancer mortality and morbidity worldwide. We know that it's actually the incidence and the mortality affects the low and middle income countries disproportionately. So the purpose of the reason why we conducted this study is to describe the global landscape of clinical research into interventions for GI malignancies, and also to understand the participation among low and middle income countries. Most importantly, we also want to understand the reasons for premature trial termination. So how did we go about this? We queried the clinicaltrials.gov database on October 26th of 2022 to identify all phase 3 clinical trials that were either terminated, permanently suspended, or completed. So we define permanently suspended as anything that's been suspended for more than 1.5 years. So the reason why we use clinicaltrials.gov database is because up to today, it's still the most comprehensive data set for clinical trials. We all understand it might be a little bit biased to North America, but it still gives us the best chance of identifying ongoing and completed clinical trials. So to my left, you will see a flowchart of how we identify our studies. When we initially started, after imputing our search criteria, we generated over 9,000 studies. After imputing all our inclusion and exclusion criteria, we were able to come up with 179 unique studies. Next slide. Oh, back. Okay, so this is just an overview. I would like to point out one or two things there. So one thing is 94% of the trials were randomized. And what we noticed is 16.2% of the trials were terminated prematurely. From the terminated cohorts, the most common reason for termination is patient accrual difficulties, which accounts for 44% of the terminated trials. You will see that gastric adenocarcinoma is the highest patient population, accounting for 70%. If you look at the map center, which is what I actually want to call your attention to, you see the figure 1 is a map that is describing clinical trials across the world. The color density correlates with the density of the clinical trials. We will see, so I will call your attention to the comparison. You will look at figure 2 and figure 3. These are maps that we adapt from another tall publications in 2020. So the left side of my screen is the one for gastric cancers, cardiac and non-cardiac gastric cancers, while the right side is for esophageal cancers. Those are the age standardized incidence rates. If we compare the incidence of these cancers to the clinical trials, one thing that jumps out to us first is we'll see the disparity in the clinical trials and the age standardized incidence, especially pronounced in South America and overwhelmingly glaring in Africa, where there's almost non-existent clinical trials. Next slide. So after looking at all this, we extract the characteristics of these trials. We did a multivariate regression analysis to understand for the terminated and completed trials, what are the factors, independent factors that will predict termination of a clinical trials, and what are the factors that might be protective. I will highlight to you that the factors that predict on termination, one is esophageal squamous cell carcinoma alone. Any trial that is investigating esophageal squamous cell carcinoma alone is more likely to terminate than others. And also, if you look at the forest plot on the left, if you look towards the end, any trial that have sites that are exclusively in the US are more likely to terminate. And surprisingly, we find out that any trials that involve sites in non-high income countries, that is, any trials that involve sites in low and middle income countries, they are less likely to terminate, which means they are more likely to complete their trials. Same thing goes with trials with more than 50 sites. The histogram to my left is just an overview of the number of trials, the number of trial sites, comparing it with the incidence, with the crude incidence. We could see the disparity, especially in low and middle income countries. Final slide. So this is just a discussion and conclusion of, although more than 80% of gastroesophageal malignancies occur in low and middle income countries, the clinical trials activities disproportionately occur in high income countries. And very few of these trials focus on esophageal cancers, despite it being a very lethal disease. And this shows an important area of unmet need. One thing that I pointed out is geographic location of clinical trials and number of sites are the most important predictor of trial termination. And studies that involve low and middle income countries are less likely to terminate prematurely. So in conclusion, this finding highlight the potential role for multinational trials with low and middle income sites to advance clinical research for this priority disease. Thank you so much.
Hello, everyone. My name is Fatou Diallo, and I want to thank the Abstract Committee today for selecting me, and also want to acknowledge and thank the Ministry of Health of Peru and the different health system participants in Lima. So my talk today is design workshops, participatory co-design and interactive adaptation of cervical cancer screening implementation plans in Peru. So as we aim to close the research to implementation gap in the cancer continuum, we must consider having meaningful participatory engagement with health system planners and actors. Research has shown that it leads to plans that are more likely to be adapted and are also more sustainable. We also need to consider the context in which the service or the intervention is being implemented. What are the circumstances of the implementation effort, or what are the characteristics that surround it? It's not going to be a one-size-fits-all. And lastly, we need to better understand how and why some interventions work, and basically to be able to develop strategies that can then be adapted in other contexts. Next, please. So what I just described is part of what's known as embedded implementation science, right? It brings together scientific experts and implementers so that they can share relevant knowledge that can be used to facilitate the implementation of either a service or an intervention. Basically, the interventors will share information about their implementation process. What is it that they're doing and how are they doing it? The experts will likely be very diverse based on what the implementation needs are. And basically, while there's this bidirectional communication between the two, and what the scientists will then do, or the experts, is that they can tailor implementation strategies to mitigate the barriers and leverage facilitators. The implementers will provide feedback as they're employing these strategies, and then let the scientific experts know, oh, this is what's working, or this is this is what's not working. And so there's really this ongoing communication between the two groups. And so what we've done at NCI is that we have a preliminary model of embedded implementation science, and we worked with partners in Peru who were just starting to implement an HPV-based cervical cancer screening program. And so the goal was to test the feasibility of conducting a 4-day series of participatory co-design workshops in the northern region of Lima. The activities started with an intensive planning phase with the Peruvian ministry and a team of both regional and international experts in various and relevant fields, and of course the NCI team. And together we defined the goals of the workshop, whom to invite to participate, what the structure would look like, and also the outline of the agenda. We also developed a web-based scenario tool to help with assessing the feasibility and scalability of the program. Next, please. So for the workshop, from the beginning, we knew that it was going to be very important to set the tone and build trust with the participants. And this will allow them to just be free in sharing and whatever their thoughts may be, and what their process was, without fear of being judged. And as you can see in that bottom left corner, this was the layout of the room. And this was very intentional, right? All the participants were on equal footing, sitting on the same level. And we had the scientific observers. In this setting, we had them in the back, and they were not really visible to the participants who were sitting at the table. And it was just to limit distractions, but they were able to hear everything that was happening. And the participants included the Peruvian Ministry of Health. We had midwives, laboratory and technical staff, doctors such as gynecologists and oncologists. We also had a great facilitator who understood the local context and the health system and political dynamics, which made it very productive. Next slide, please. So participants were asked to reflect on their screening process, right? And what did we learn from this reflection? When healthcare professionals or the practitioners were in a safe space, they were able to fully engage in the discussion, and they were asked to share about their experiences with the screening process. And while they were sharing, we were mapping out this whole process in real time, as you can see on the whiteboards. And they were able to visibly see the complexity of the system. And in fact, one of the challenges that they realized was that, let's say they were screening 100 women and sending them to the hospital for follow-up, the hospital wasn't able to manage those 100 patients. So those patients, some of them were getting lost to follow-up, or just somewhere within the system, they weren't able to get back in touch with them. So what the midwives realized is that from their end, like instead of screening 100 women, they could actually screen less so that those patients can move a lot more easily through the system, through the healthcare system, so that the hospital can better manage them. And so they were really able to participate fully and be engaged in the discussion and share what their thoughts were, and participate in the problem solving and also in the decision making. And in fact, they identified some short and medium and long-term goals with this. So the next slide, please. Okay, so to bring it all back together, I was thinking about, so you have this model of the implementers and then the scientists, right? And they're continuously in communication with each other. And so while the conversations were going on, basically they were able to map out in real time what was happening. And so we were able to walk away with some conclusions. For instance, learning that some of these barriers that they were facing, the scientific experts will be able to kind of tailor implementation strategies that will be beneficial to the Lima region, but of course may also be adapted in other regions in the area. And that's it for my talk. Thank you.
Good morning, good afternoon, everyone. My name is Mariana Nobile, and I work at the International Atomic Energy Agency. Today, I will present the abstract that I've been working on with Dr. Ralefala, Dr. Leshimpi, and Dr. Mudavanu, that are representatives of the Ministry of Health of, respectively, Botswana, Zambia, and Zimbabwe. And I thank them for their commitment for this project. With this abstract, we wanted to showcase how the support provided to African countries to develop a national cancer control plan contributed to strengthen South-South cooperation to tackle the rising burden of cancer. Next, please. As you know, a national cancer control program is a public health program designed to reduce cancer incidence and mortality and to improve the quality of life of cancer patients. The IAEA, through its Program of Action of Cancer Therapy, works in collaboration with the WHO and IARC to assist member states to address the challenges that cancer presents. One of the services provided within the framework of the WHO IAEA Joint Program on Cancer Control is the advisory support to develop a prioritized, evidence-based and country-specific NCCP. Next, please. Next, please. Thanks. In this slide, you can see the NCCP development process, which starts from the request by the Ministry of Health of a specific country and continues through different drafting phases until the official launch and dissemination of the NCCP. The process includes the identification of the country's needs and capacities through a detailed situation analysis, regular meetings with the team appointed by the Ministry of Health, and in-country workshops with national stakeholders, including civil society organizations, academia, and cancer survivors. The key aspect of this process is the engagement of regional experts who are involved to give a strategic direction to improve cancer prevention and control services, taking into consideration common best practices and challenges. Next, please. In the African region, the involvement of regional experts contributed to strengthen South-South cooperation through the creation of a network of cancer control professionals that can share experiences and lessons learned, paving the way for possible partnerships to implement cancer control priorities. As you can see in countries such as Botswana, Zambia, and Zimbabwe, this approach facilitated the establishment of a dialogue that fostered longer-lasting mutual support for capacity building and the exchange of knowledge to advance the implementation of cancer control activities in sustainable ways. For instance, as you can see, Botswana supported Zambia to introduce HPV testing in cervical cancer screening program. Zambia assisted Botswana in providing capacity building in radiation oncology, and Zimbabwe is currently supporting Botswana in the development of its first ever NCCP. Next, please. The development of an NCCP is a critical first step to ensure that effective national response are put in place to reduce the challenges posed by cancer. A robust NCCP becomes also the foundation document to further support countries in establishing or expanding radiation medicine services through different initiatives, such as the recently launched Rays of Hope initiative, which is directly contributing to fulfill the 2030 Agenda for Sustainable Development Goals. The priority activities included in the NCCP need to be implemented through strategic partnership, strong coordination mechanism, and resource mobilization to achieve the objective of reducing cancer incidence and mortality. Therefore, to strengthen collaboration activities and ensure the sustainable implementation of the NCCP, Botswana, Zambia, and Zimbabwe will conduct quarterly virtual meetings to share best practices and lessons learned. To conclude, I would like to thank Dr. Alefala, Dr. Lishimpi, and Dr. Mudavano, that are the co-authors of this abstract, for their dedication to strengthen cancer prevention and control, not only in their countries, but in the African region. They are just an example, representatives of all the countries that are currently part of this project to create a network of cancer control professionals in the African region. And I think that this is really the right way to improve cancer control in the African region. Thank you all.
Yeah, sorry. Thank you so much. It's a great honor to present our work of harmonizing the cancer registration guidelines in East Africa. As you may all know, implementation of evidence-based cancer control strategies require cancer registry data to direct the cancer control efforts. However, cancer registration in East Africa is characterized by various disparities in quality of data and coverage. This work aimed to harmonize the cancer registration guidelines in East Africa to improve our network and enhancing cancer registry data in the region. Next slide, please. Yeah, we used several approaches, and the most base was a participatory approach that involved all the East African member states, that is Uganda, Kenya, Tanzania, Rwanda, Burundi, and South Sudan. And we also formed the partnership in leadership and everything. We had a planning committee, a steering committee, and writing team that all composed of members from the different 6 countries, including the Secretariat. We also reviewed the literature about the available cancer registration guidelines globally to really have a benchmark on how to base on when we are developing the guidelines for the region. We also conducted a SWOT analysis to really be sure and establish the need for the cancer registration guidelines in the region. And finally, we conducted 3 harmonization conferences, one in Tanzania, one in housed in Nairobi, and another one in Kampala. And next slide. Yeah, the results of the SWOT analysis indicated that actually most of the cancer registries were established in the last decade, about 70% of them, and the majority, about 80% of them, are supported by government. And although they have a staffing capacity of 1 to 3 staff overall per registry, with the responsibility of registering about, on average, 400 to 1,000 cases annually. We also found that cancer was not a reportable disease in many of the East African countries, apart from one, and still many countries didn't have a policy regarding cancer registration. It's only one country that had one, that is Kenya, but also it was not reinforced. Next slide, please. Yeah, so along the process, including all those approaches, we are able to have the harmonized cancer registration guidelines for East Africa that were approved by the East African Community Secretariat and Ministry of Health Council in December 2021. These guidelines now indicate and outline the governance, leadership, and oversight of cancer registration in East Africa. They really provide the requirements for establishing a cancer registry in East Africa. Before that, anybody could just come and establish a cancer registry anywhere with the few resources they had, and this contributed a lot to the collapse of the so many established registries that lacked maintenance funds and sustainability. The guidelines show really the regulations regarding data collection, the ownership of data, and sharing of data from cancer registry. It shows how to go about partnership and collaboration, and it provides guidelines for implementation of these guidelines by the individual member states. And through this development, we are able to enhance the ownership of the data and the accessibility of the data by the member states. And the process provides learning opportunities, networking, and the collaboration that was not there before. And of course, a strong policy tool for advocating for cancer registration in the region. Next slide, please. Yeah, so in conclusion, we really learned that although some challenges still exist, there has been an increasing number and interest in cancer registration over the last decade in the region. Most registries are affiliated to government institutions, and this provides and demonstrates that government is willing and committed to support cancer registration in the region. And this provides a great opportunity for improving cancer surveillance in the region. We also learned that use of local structures and the local leadership structures are very important in improving cancer registration data and overall cancer control strategies in the region. Thank you so much. That is the end.
I would like to thank our speakers for these fabulous presentations, encouraging and increasing global cancer research. We just heard from presenters from 6 countries covering 4 areas of cancer control continuum, such as curative treatment, non-curative treatment, adherence, and symptom management, that really highlight this year's theme of this symposium, which is closing the research to implementation gap. I would like to invite you to find all of our presenters, as well as other accepted abstract presenters, on the Gather platform tomorrow. I would like to thank all the attendees for joining today, as well as to thank Dr. Ophira Greensburg for her opening and inspiring remarks. I would like to note that the scientific session on learning from our peers reminded us that the cancer research and control community can learn from and build on advances in HIV control strategies. It was great to see how much interaction we saw today and to see our other sessions. We got to see proper implementation of the screening tools and adequate time from testing in HPV detection can really have an impact on early diagnosis and subsequent treatments. It was great to see Dr. Nair results on how to say self-obtaining samples for cervical cancer screening. And this is an alternative strategy for women living in rural areas and really has shown a difference, and probably it's going to get more and more implemented and accepted by our females with cancer. We had 2 abstracts that really provided us evidence on a smoking cessation in a pressing strategy that has a positive impact in HIV patients. I would like to thank Dr. Huang and Shelley for showing these implementation intervention campaigns that have already shown promising results in the field. I think we also got to see the effect that public health campaigns and novel electronic resources can have on awareness of cancer, particularly this time on gastroesophageal neoplasm on vulnerable population in Asian countries. So I really think all these strategies help to move forward the global cancer research and the global oncology field. So we're really excited about these presentations. We would like to welcome all attendees to join us in our 3rd and final day tomorrow. We will show a slide regarding, the agenda for tomorrow. The second and final scientific session will be on connecting for cancer control, a collective action through the Global Alliance of Chronic Diseases Network of implementation projects. We would like to remind all attendees that they will be able to meet the abstract presenters during the second interactive poster session at the Gather platform. And finally, I would like to hear from the 2023 Rachel Pierline awardee, Dr. Jinlin Wu. Dr. Jinlin Wu, as you may know, is a professor of obstetrics and gynecology at the University of Malaya at Kuala Lumpur, Malaysia. She conceptualized and implemented the program ROSE, an innovative cervical cancer screening program incorporating self-sampling for HPV. Please welcome this event. You know, it's rewarding to see this award in the hands of someone really promoting global cancer control. Finally, if you're unable to join us tomorrow, please provide your feedback by completing the post-conference survey. It really means a lot to us to have your perspectives and comments on the meeting today so we can improve in future events. I would like to thank my co-chair, Dr. Hawa Kamara, for leading this session and all the speakers for their innovative ideas helping to promote cancer control worldwide. Thank you very much.